There are many sources of pharmacokinetic variability. And in this slide, on the left-hand side, we've listed patient-specific factors, and on the right-hand side, I would say that these are so-called drug-related factors. As it relates to patient-specific factors, there are a number of elements that one needs to consider. Um, the function of the normal liver and kidney, so organ function, the status and extent of the disease, sex can play a difference. We also know that there are significant uh, underlying genetic differences as it relates to drug absorption, drug metabolism, and drug excretion pathways. Race can play a key role. Age, height and weight for sure. And it's interesting, height and weight, right, makes up the body's surface area. But as you can see, just with respect to patient-specific factors, there are a lot of other factors in addition to just height and weight. And now we're also appreciating that there is diurnal variation in how we can metabolize and clear a number of drugs. And this has to do with circadian variation. As it relates to drug factors on the right-hand side, the mode of administration, IV bolus versus continuous IV infusion, the issue of drug-drug interactions, as more and more of our cancer patients are taking either herbal supplements, herbal medicines, and or nutritional supplements, that can impact on drug absorption and also can impact on drug-drug interaction um, aspects. Food obviously is a huge variable. And if one is taking an oral medication, the issue of patient compliance and patient adherence are also factors that one needs to take into account. So there really are a wide number of variables that go into this issue of pharmacokinetic variability. Now, as it relates to the concept of therapeutic drug monitoring, which has to do with routine testing of drug levels as we dose drugs, I think this is a very common occurrence for those of us who are prescribing non-cancer associated drugs, which are shown here on the left-hand side. So a number of antibiotics, including gentamicin, vancomycin, dosing of anti-epileptic medications, including phenytoin and phenobarbital, the use of theophylline in the treatment of asthmatics and COPDers, patients who are on antipsychotic medications such as lithium. Perhaps the best drug where we have to monitor PT and INR very, very closely is in the use of oral anticoagulants such as Coumadin. In the world of cancer, relatively less has been done in everyday clinical practice in terms of monitoring drug levels. Obviously, we'll focus much of our attention this evening on measuring 5-FU AUC plasma drug levels. Commonly we measure methotrexate levels, but it's not to decide what the subsequent dose of methotrexate will be. We use methotrexate levels to figure out what the dose of leucovorin should be. For carboplatin, we use AUC dosing, but we really don't measure carboplatin or cisplatin levels. In patients who are undergoing transplant and receiving busulfan, high-dose busulfan, there's a clear correlation between the drug levels of busulfan and efficacy of transplant. As I mentioned, we'll talk about 5-fluorouracil. And there now is emerging data suggesting that plasma drug levels of the taxanes, either paclitaxel or docetaxel, actually can be correlated with toxicity and ultimately drug efficacy. And there also is, I think, growing evidence that plasma trough levels of the targeted therapy, imatinib, for the treatment of CML, also can be closely correlated with ultimate clinical efficacy. For any drug, there's kind of an optimal therapeutic drug range, the so-called sweet spot. Below that sweet spot, when the plasma drug levels are too low, that can lead to a lack of clinical activity, which obviously then would be associated with poor clinical outcomes, which can then also lead to a higher cost of disease progression, disease recurrence. If the drug levels are above the optimal therapeutic range in the so-called toxic range, that can obviously lead to increased incidence of serious adverse events, which can then lead to premature termination of a treatment that may actually be working. That can lead to increased myelosuppression, neutropenia, which can then compromise the overall immunity of an individual patient, and that can lead to increased treatment costs. So ideally, one would like to measure the drug levels, and the pharmacokinetic parameter that has been most closely correlated with clinical outcomes is the so-called AUC, area under the concentration drug curve. Please feel free to email me directly. My email address is chue2, so that's chue2 at upmc.edu.